Well, I guess I'll get us started here. It's 9 o'clock, so I'd like to call the Neighbors of Dunn County Committee meeting to order here for April 28th, 2022. I see from looking around that everybody on the committee except Larry Bjork is here, and Larry is excused. We wish him well on his new hip. Welcome to, we have all new members except for me. So I think we'll have quite a learning curve to go in, and I can use it too. There's so much to know and remember, but it's good. The first thing then, approval of the minutes. If you've had a chance to look at the minutes, I'd take a motion to approve them. Supervisor Breslin, move to approve.
Second.
Supervisor Witzel seconded. Any discussion? Changes? All in favor? Oh, that's right. Well, we will just say that we voted that you agree with me that they're okay. You're right, Don. We will look at that and I'll ask about that. Thank you. And everybody would abstain. They look good to you, right, Carmen?
Great.
Yeah. Okay. Okay. I guess we'll go with that. Is there any public comment? No public comment. Okay, then we'll go right into number 5, which is, this is pretty much the procedure we go through each meeting. Looks like this. So Carmen?
Thank you. And
Carmen,
oh,
before you start, could I get the supervisors to say their names? I can't see them on the right-hand side of my screen.
okay. If everyone would press the button to the right, and then if you could just say your name so that Chris can write them down for the meeting.
Supervisor Sean Breslin.
Don Keeter, Kuether.
Supervisor Witzel.
And then Supervisor Bjork is not in attendance.
Okay, thank you.
All right. As Chairman Kinnear said, welcome. It's great to have a new committee and new faces. So as he said, that this is kind of how we generally go. Most of these items are monthly items and we go through the same thing, just what happened that month. Sometimes like today, there are some additional items that may not be on there every month. Sometimes things that are either new topics, things that someone on the committee would request, things the chairman would request, things like that. So if there's anything that you would like to see added, changed, whatever, please let me know and we can add things as well. So this has been pretty consistent, at least for the last 4 years that I have been here. These have been the items on there. Obviously, some things have been added, like COVID update was not there pre-COVID, but things can change as well if there's things you would like. So please.
Just if there's something that anyone wants added to the agenda, talk to me, please.
Yep.
And then we'll work it out with Carmen. Thank you.
All right, so first we're going to start with the Neighbors of Dunn County introduction, and which was brought to my attention is some people might not know the acronyms as well. So if you ever see NDC or TNDC, that's the abbreviation for the neighbors. So it's just a long title to write out, and sometimes it doesn't fit in certain settings for like meeting invites and things like that. So the Ndc introduction. So Chairman Kinnear did ask a couple of questions that would be helpful to new members that may not know much about the neighbors. So I'm just kind of going to go over those. And then if anyone had any specific questions that they would like to ask as well, I can answer those. So first of all, the Neighbors is a skilled nursing campus. So we actually have 3 separately licensed skilled nursing facilities. They all operate as one campus under 3 different licensures. So in the eyes of the state, we are actually 3 separately licensed nursing homes, but we do operate it as one campus with all same policies, rules, things like that, and all kind of work together as a campus. So it's a little bit confusing. So when we ever have anything that is state related or federal related, we do it 3 times. So if we have what's called a survey, which is our auditing process, we do that 3 times. Our financials are reported 3 separate times, things like that. It was something that was created to actually get a benefit from the state for being under 50 beds, which was a benefit when the buildings were built. So when we moved from this building, which used to be the Dunn County Healthcare Center, to the Neighbors of Dunn County in 2013, the licensures were split up into 3 separate buildings. So it's kind of the history of why that is. I gave you all a map. So that is actually the layout of the campus. So in the middle is the central neighborhood. So that is one of 3 neighborhoods. It's a little bit bigger than the other 2. That is not necessarily bigger in the size of resident rooms situation. It's just that core central area is larger. So it's anywhere that if there's only one of them on campus, it's in the central building. So our main kitchen is in the central building. Our therapy gym is in the central building. Anybody's office who there's only one of. So for example, my office is in the central building. So that's why the central is a little bit bigger. And then to the right on the map is the east neighborhood. That neighborhood and the west neighborhood are the same. They are just kind of flip-flopped. So the only difference with the east and west neighborhood is they are home to our 2 memory care households. So on campus, we have 9 total households, 2 of which are memory care, 2 are post-acute rehab, and then the rest are traditional long-term care skilled nursing. All across campus, it's all skilled nursing, licensed skilled nursing, certified by both Medicare and Medicaid, which I'll get into a little bit later. But all the houses are kind of designated to be a certain care setting. So Eastbrook Lodge and Red Cedar, which are the outer 2 most households on the sides, those are 2 memory care households. And then in the central building, Fireside Manor and Arrowhead Lodge are 2 post-acute rehab buildings. In total on campus, we can have 137 residents. So that's how many beds that we are licensed for by Medicare and Medicaid. All beds have to be licensed. So we can't just add an extra bed or take a bed away. It is all a process through the state that you have to pay for licensures for the beds. That also means that we pay what's called a bed tax. And it's basically the fee for monthly licensure of the beds. If there is a resident that is living in the bed, that is part of the cost of the stay, basically, depending on payer source and things like that. If the bed is empty, we pay that as a facility. Currently, we have about 100 residents on campus has been our average. Fireside and Arrowhead are currently closed. That is primarily due to staffing. We are currently in the process of opening Fireside again, which I'll get into a little bit later in my report. So hopefully we will get that census back up again. We have been able to secure more staff through a state staffing agency that will allow us to do that so that we do not have as many empty beds. Any questions about the general campus before I continue on? No? Okay. As I kind of mentioned earlier, the original building or the last building before the Neighbors was this building, was the Dunn County Healthcare Center. This is our 3rd campus that we've had. The original building was kind of spread across all of our space now, which was the Dunn County Asylum, which opened over 200 years ago. And it was basically the place that anyone that needed care would go. So it's almost 200 years. So we'll be there, I think, next year. So that building was before there was such thing as skilled nursing facilities or long-term care. So it was home to anyone who needed extended care outside of like acute care hospital setting. So it included anyone with a mental illness, it included developmentally disabled, and then the elderly that needed care. That operated for 80 years before this facility was opened, that the Dunn County Healthcare Center, which then operated for 40 to 45 years. I can't remember off the top of my head. And then the neighbors were built. So we're actually in our third campus that the county has owned for a healthcare center. Over the last 200-ish years, we have obviously the model has changed of healthcare as the industry has changed, but we still do serve the county's residents that need extended care. We do not have a developmentally disabled license or a psychiatric license anymore. The Dunn County Healthcare Center did for about half of its operation, but we no longer hold those licensures. Okay. So the capacity, I already talked about that a little bit. And next one on here was types of staff. So skilled nursing facilities have a lot of different levels of staffing in them. We have RNs, LPNs, so which is a registered nurse, a licensed practical nurse. It's just a different level of schooling for nursing. For the most part, they do a lot of the same things. The main difference is things like IVs, wound care, stuff like that may not be as advanced through the licensed practical nurse program versus the RN program. And then we are required to have an RN on campus, or actually in each facility, for a minimum of 8 hours a day. So that's also, we can't have all LPNs. We do have to have some RNs. Our central building has an RN in it 24/7 is the goal, especially when we have our rehab open. And then that individual is also the charge nurse for the campus. So if anything were to go wrong at 2 a.m, that is the person that makes the calls at that time. We also have what's called a homemaker position, which is a little different than a lot of skilled nursing facilities. Skilled nursing facilities a lot of times have lots of different environmental service positions like housekeeping, laundry, things like that. We have a more universal care worker setup. So homemakers fill in a lot of that position. And then our CNAs also do take on some of that workload. That is why we do have a higher staff to resident ratio. So we have more staff or less residents per staff member than a traditional skilled nursing facility, but that is primarily because they do more than just the average CNA work. So it adds a little bit different tasks instead of just adding more tasks to them. So we try to have a 1:8 ratio for CNAs. So that would be 1 staff member to 8 residents is our goal. And that would be typically 2 staff members, 2 CNAs in each household if the household is full. The households fit about 16 residents, some are less than that, but at the max it's 16. And we also have dietary staff. Excuse me. We have dietary staff that work primarily out of the main kitchen in the central building. And then our food is brought out to each of the households, each of the neighborhoods, and then into each households from that kitchen. There's little kitchenettes in each of the households. So the dietary staff does not physically serve the food. That is done by the homemakers and the CNA staff. But the dietary staff prepares the food in the central kitchen, and then it is brought in heated golf carts, for lack of a better term, out to the other neighborhoods. We have therapy staff. We have contracted therapy staff through Genesis Rehab. They are there to provide therapy for both long-term and short-term residents. Primarily short-term residents are there for therapy, so that takes up a lot of their time. But we also have residents that are there at long-term that would be receiving therapy for either a restorative program, if they've had a change, so they might be on Medicare Part B, which would be just the therapy part during a long-term stay, or if they just have a decline and need some sort of assistance to get back to prior function or learn how to adapt. If they say they went from using a walker to needing a wheelchair, we would probably have them on therapy to help them learn how to adapt to their new setting and needs. So our therapy staff are there. Their main therapy gym is in the central building, but they do serve all 3 neighborhoods. So just because someone would be in east or west doesn't mean they wouldn't receive therapy. They would either go out and do therapy in the households, or they can bring residents to the central gym if they need some of the equipment that would be in there. We also have social services staff. So we have social services for all 3 neighborhoods. They would be the staff that talk to residents if they have concerns. They're there to help with guidance on admission and discharge. They are there to do assessments of residents. Social service assessments are part of our requirements for what's called the minimum data set, or MDS, which is how we do our billing, which is a very long, deep discussion that we won't go too far into, but it basically is a large data collection on each resident about their needs. And that gives us basically a code that relates to that resident. And then that's how much we're able to bill for them depending on that code. So the higher the needs, the higher the payment from Medicare and now Medicaid. We also then have administrative staff. So myself, Chris, who is on the call, he takes our minutes for this meeting and then also goes over HR. We have management staff across campus, including our nursing staff. Paula is our director of nursing, or clinical mentor for the whole campus. And then we also have an assistant clinical mentor for the 3 neighborhoods, 1 in each. They're kind of the go-tos for that neighborhood. They know the residents, 45 or so residents, if they're full, the best. So clinical care wise, they are the people that people would go to for that neighborhood, as well as they round with the doctor. So we have a doctor on site, a doctor, NP, or PA on site Monday through Friday, which is much more frequent than most skilled nursing facilities. But we do have a very large campus, so they are always busy when they are on site. And the 3 nurses that are the assistant clinical mentors work directly with the physicians and bring them to the residents that they need to see. And then for other staff and how we kind of relate to the county. So we are in a different building. We are next door in the 3 buildings. So we don't have offices here at the government center, but we do work directly with the government center staff. So we have IT comes out to us and helps us. Human resources, Chris is our extension of human resources on site, but we do work with the human resources department here. Finance is a big part of that as well. Jane Hansen is the accounting manager who works directly with the neighbors, but we do work with a lot of financial staff that work for the county. And then any other department that is shared throughout the county. So Corporation Council, if we need them for anything, we would go to them as well. And then currently, Nick would also be my direct supervisor, who is the interim county manager. So we do interlace with the county as well. And then Scott is also here today too, and his team works with us. So they're not directly neighbors employees, but work with us as well. So it's all intermingled with the rest of the county. I'll go over a brief description of how NDC is paid. So we have a lot of different payer sources. You'll see that on our financial statements as well later on, but we have skilled nursing can be paid by a lot of different sources. Our primary payer sources are Medicare, Medicaid, private pay. We do have some VA residents, and then we also do take insurances or like Medicare insurance. So we primarily, we see a lot of Medicaid and a lot of private pay, or some private pay. Medicare is dependent on census. That's the one that goes up and down frequently based on how many admissions we're taking. So lately we have seen a lower Medicare census just due to our having 2 closed households. We do have some residents that have been admitted to East and West that are Medicare. That is just based on bed availability though. We hope to see that increase with the opening of Fireside coming in the next week or so that we will have more Medicare as a payment source. All of these payment sources are different. They all give different rates and they all give different systems through different organizations. So Medicare would be typically short-term rehab. And that is one of our better payer sources. It is higher acuity residents, and that is paid through the federal government. Medicaid is a 50-50 federal government and state payment system. It is guided by the state. That is our lesser payer source. We do have a lot of Medicaid residents, but the rates are lower than, say, Medicare. Private pay is what it sounds like. The residents are paying for it privately. So the resident or their family is paying out of pocket for their room and board. And then anything additional, they would also be paying for. So if they wanted therapy, they would pay for it, or their insurance or Part B would pay for it. If their medications, all of that is out of pocket. In a system like Medicare, everything that is paid for through that rate. So if they need a different medication, we pay for it. It's part of the rate that would come in. So the hope is that what we're getting for the rate for Medicare is more than what we're paying for whatever the resident needs. But that's an all-inclusive rate versus the private pay rate is just the room and board, which would include the room, food, just the basic care needs, and obviously the staffing and things like that. But then anything extra they would pay for on their own. We do take Medicare-like insurance, which would be those insurance companies that you see the commercials for that say, buy our insurance plan, it's like Medicare. We do take those. We don't see a lot of it. It is popular in other regions. We might see that coming in our area soon. We do see some, but say down like by Green Bay and stuff like that, that's a big portion of their payment system. Up here, we on average probably have 2 or 3 residents at a time that are on an insurance plan. We are a VA contract, so that means that we do take Veterans Affairs payments and residents, which that's typically done with one facility per county has a VA contract. They don't go to all facilities. So we are the contract for Dunn County. So we do at times have a handful of residents that are on VA insurance, either for a Medicare-like stay and sometimes hospice stays and things like that as well. VA is a very different payment system. So they cover some things and not other things. So it's a little bit more complicated than some of the other payment systems. You know, that's probably less helpful than it is. But if anyone has any questions about the payment system that I can answer right away.
How often are the medications for Medicaid higher than what the allotted rate is?
For Medicaid,
Or Medicare?
Medicare. We try really hard to not have it be higher. So we check those medications prior to them coming to us. So there's some things like chemo medications that are extremely, extremely expensive. Things like that. We try to, some are cut out of the payment. So there's some things that Medicare gives kind of a pass for because they know that it's too expensive and no one's going to be able to cover that. So we try to do our vetting very well in advance. The kicker is when it happens after they've already been admitted to us that something gets changed, but that's not very often. It may be a handful of times. It's not a huge thing, but it's something that we do look out for because there are a lot of very expensive medications out there. Good question. All right. And if there's ever, I'm sure there'll be more payment system questions and there's changes to the payment system on a very regular basis. And whenever that happens, I try to give not too deep dive spiel, high level spiel of what has changed. For example, our Medicaid payment system completely changed over the last couple of months. So that has given us a different way of recording rates and things like that. So I try to give a very high level description of that without getting too in the weeds whenever those happen. So I will do that if that occurs. The next thing on here is explain the rules of skilled nursing facilities and who monitors them. So skilled nursing facilities are monitored and what's called surveyed by CMS, which is the Centers for Medicare and Medicaid Services. So they are our general overseer. It is a federal government system. So they oversee all skilled nursing facilities in the country. They set a base level of rules, which is called the standard operating procedures. And it basically gives all of our regulations. Fun fact is skilled nursing facilities are the #1 regulated industry in the world. We have more regulations than nuclear power plants. Which sounds a little crazy, but it's for good reason. We take care of very vulnerable people, and it is our job to make sure that we're doing everything that we should be doing. For the most part, most of those rules are fairly common sense. They are things that is just what anybody should be doing. Unfortunately, there are people that do things that they shouldn't be doing. So that's why there's all those rules. On the other hand, there are some very complicated and seemingly tedious rules as well. But we work through them, and those rules also do change on a fairly regular basis. We've seen rapid changes in those rules over the past 2 years with the pandemic. But even before that, there was quite a bit of changes. So the state of Wisconsin is also involved in our survey and regulatory process. So the federal government sets those base rules through CMS, and then every state can also add to those rules through their Department of Health. So the state of Wisconsin has a set of rules that is different than Minnesota, that's different than Illinois, and it can be above and beyond the federal requirements. It can't be less than. So we have to meet whichever one is stricter for any sort of situation. So this, every state is different. I've previously worked in Illinois, and for example, whenever we have a misconduct reporting, Illinois has 72 hours to report it. The state of Wisconsin has 5 business days. So it's just based on whichever the state wants to determine. So we also follow their regulations. Then for monitoring those regulations, we have what's called surveys. They happen annually at a minimum. It's every 9 to 15 months is what the actual range is. So state surveyors are typically who come and survey us. They survey us on the CMS regulations as well as the Wisconsin regulations. So we have to meet both of those situations when the state surveyors come. So the state DHS is contracted through federal CMS. We can also have federal surveyors come and survey us as well. This is less common. It happens every so often. I believe, I don't know the validity of this, but I believe it is said that it's about 2% of facilities get a federal survey every year. So it doesn't happen very often, but it can. We did have a federal survey this past year for life safety code survey, which is one part of the survey process. So it does happen at times. And they can either come with the state surveyors, so they'll just send a federal surveyor with them, or they can come after the state surveyors and do what's called a look back survey. So they basically resurvey and see if the state missed anything. And then we would get a report as well as the state would get a report. Our federal surveyors would come out of the Chicago region. So they have a regional setting for CMS. So they would come from Chicago, and then our state surveyors come from Madison, or they come from Eau Claire, but it's through the Madison state survey system, but they actually come out of the Eau Claire region. So they come in and they look at everything throughout the nursing home. They only survey one of the 3 neighborhoods at a time. So we get 3 state surveys a year. Luckily, they are spread out across the year instead of one right after another. So our next state survey will be in our east building sometime soon. They came in May last year. So we're expecting them shortly. And then after that, it's west, which comes sometime at the end of the summer. And then central is normally like November, December. They can change timeframes because it is 9 to 15 months. So they can come earlier or later, but it's typically right about at a year. When the state is here, they come in typically 3 to 4 surveyors. It's unannounced. We don't know when they're showing up. They will walk in and they'll say, we're here for your annual survey. Then basically some of the surveyors will go out into the households and they will start observing and talking to residents. And then one surveyor, typically the lead surveyor, will sit and talk with myself and the nursing managers and go over what's called an entrance conference. And we basically just go through the things that every survey looks at. And we have a book that is pre-prepared for them that we just say, here you go. And it has everything they're looking for. It saves a lot of time when they're asking a bunch of questions, because most of those things don't change. It's policies, it's times that we serve meals, it's things like that. So we can have that ready for them in advance. And then they are there for about 3 days if everything goes well. And then they leave, they talk to every resident. There's things they have to watch. They have to watch meal pass. They have to watch medication pass. They do an interview with the nursing managers for infection control. They do an interview with myself for our QAPI system, which is our quality assurance performance improvement plan, which will be the next item on the agenda. We go over that meeting every month during this meeting. And they basically do an overall look at everything in the facility. At the end of that, they tell us if we have any citations, which are called F tags. So each one has, it's an F/ and then a number, and it basically relates to some sort of rule or citation. It can be something very minimal and it could be something very drastic. Typically, we don't see very drastic citations, and knock on wood. Those are few and far between, and it would be if something very major happened. They are also rated on what's called a scope of level of severity, scope and severity. So it basically gives us, was this a very small minor thing that you can fix really easily, or was this a really big issue? The higher up on that scope can relate to fines. It can also relate to non-payment. It can relate to not being able to admit to the facility, depending on the level of that citation. Those are called immediate jeopardy citations. So those are things that have to be fixed before the surveyors leave, and it means that it caused actual harm to a resident. These are not common. They do happen across nursing homes everywhere. We have not had one in many, many years, but they can happen. And basically you have to fix whatever the issue is before the surveyors will leave your building. And then you have to have a larger plan of correction as well. Those can also go through a full process of dispute resolution and things like that, which I won't get too deep into because it'll take a long time to explain. But we can fight those citations as well if we don't believe we should have received them. Typically, facilities in the state of Wisconsin on average have, I believe the current rate is 6.8 citations per survey. And I believe the federal rate is somewhere around 8 right now, citations per survey. Our survey history has been very good. We had 2 citation-free surveys this past year and one survey that had 2 very minor citations, so much below average. So we're very proud of that. Survey results are very important. They do reflect specifically on the nursing home as they are publicly posted. So you can go online and you can look up any nursing home in the country's past 3 years of survey history. So you can actually read the statement of deficiency, which is the form that we receive from the surveyors after they leave us. So they sometimes tell us what they think they're going to cite, and then about 10 days later, we get emailed an actual statement of deficiency. And it'll tell you what they cited, at what level, and then we have 10 days from that to send back what's called a plan of correction if there's any citations. So that statement of deficiency is online for every nursing home. So it's very important that we don't receive citations. They are not written in a way that benefits the nursing home either. So even if minor citations look bad on those statement of deficiencies. So just for people coming into the nursing home families, it's important because those are out there. It also directly reflects on our 5-star rating. So all skilled nursing homes are rated on a 5-star basis. That is also on Medicare.gov, which is the website that the survey results are on. starts with our survey history, and then it also adds in our staffing ratios as well as our quality metrics, which also I'll talk about a little bit later through QA because that was our topic this month. So basically that all gets added up through an algorithm and then it gives us a 5-star rating. If you have a poor survey, you cannot get higher than a 4 because you can only go up 1 from your survey result. So if you have a 3-star survey, you can only go up to a 4. If you have a 1-star survey, you can only get up to a 2. So it is very, very important to have good surveys. Currently, all 3 neighborhoods are at a 5 out of 5 stars, which is great. We're very proud of that, as well as all 3 neighborhoods are listed as top performers on the US and World News nursing home performance ratings. So we are very proud of that, and that is directly related to those survey results. Excuse me. So lots of rules and lots of different things. The only other thing I had on here was to kind of discuss our current situations of different things that would be things that were discussed over the past few months that maybe you would not have had an opportunity to know about. Right now, our biggest concern, and we talk a lot about, is staffing. I'm sure that you are all aware that everywhere in the country is having a staffing concern. Healthcare had this prior to the current concern, and it has just alleviated or just escalated it. We have seen increased number of turnover as well as just staffing is very hard to come by in general. This, as I said, this was already a concern, and we've just increased the need for staff and the issues that come with it. The pandemic did directly affect healthcare and specifically skilled nursing facilities. It was very taxing and still is on skilled nursing facilities and other healthcare entities. So we did lose even more staff due to just burnout from all the added needs of going through a pandemic and working in healthcare. So that did not help our situation, and we are still seeing the effects of that today. So that is something that we talk about every single meeting as well as every single day at the Neighbors is staffing. It is definitely our deepest concern and biggest need at this time. It does also then affect things like census, which I've already talked a little bit about. That is why we have 2 households closed. I'll go over our referral report later. It's not because we've had a lack of referrals. It is just not able to have beds for them because we very strongly believe that if we can't give the exact care that we would like to give and the proper care, we should not admit people. We are there to give excellent care for our residents. So if we don't have the staff to do that, we should not be taking in more residents. So that has been the mentality that we've had towards that, as we don't want to provide poor care because that is not what we do. So that has been our biggest issue at this time. Obviously, COVID is still a situation at the Neighbors, which I'll talk about that a little bit later as well, because I give an update of that every month. That is something that we've talked extensively about over the past couple of years, and it is still going in terms of precautions and things that we have to do at the Neighbors, and that is per both state and federal regulation as well. So there's always a lot of questions, and I'm sure as supervisors, you will get questions as well about the regulations and things that the Neighbors policies. Most, if not all of those are state and federal guidance or requirements. So a lot of it, we have no change or no ability to change a lot of those things. Some of them are based on what's called outbreak status. If we have any staff or residents who are COVID positive, some are all the time. Some are based on county positivity and prevalence rates. And it changes seemingly on a daily basis. So it's something that's been ongoing for the last over 2 years now. And we see rapid change all the time. So luckily the changes have slowed down a little bit. At the beginning, it was legitimately every single day something would change. Now it's probably like once a month, but our changes go quite frequently because things like positivity rate and prevalence rate can change on a very rapid basis as well. All right. Any questions for me about the general NDC introduction? Before.
How long is your short-term rehab? I mean, how many days are they here or?
Uh, It varies,
varies.
varies. So Medicare system has a maximum of 100 days of short-term rehab that someone can receive. Very few people make it to that 100-day before they go home. They have to be making progress in therapy or whatever their need would be to be there, because you can have non-therapy skilled nursing as well, or Medicare stays if, say, someone has wound care or things like that, that would qualify them. So you have to be making progress, or if someone has returned to their base level or their max that they're going to return to, they might go home before the 100 days. We also have, if they're there less than 21 days, that is fully covered. And then after the 21 days, there's a copay. So a lot of people go home before that because they don't want to pay the copay, or they don't have supplemental insurance that would pay the copay. So we see a lot of people wanting to discharge at that point. But we do sometimes have people make the whole 100 days.
Thank you.
Thank you. That was a good summary. Thank
Good,
you.
okay.
And if it was she did a really good job.
Thank you.
And like you said, it was a short summary, and I appreciate you answering those questions. So this is when I would always ask, are your heads full yet in class? So thank you very much. That's great.
Thank you. And if there's anything that and I think I mentioned this a little earlier, if there's anything that I say throughout the rest of my report that you have a question about, because it's an acronym or a term or a thing that you don't know what it might be, as it's very niche to nursing home stuff, just please ask. I know I sometimes use things that other people don't know what they are. So just please let me know. All right, so Quality Assurance Steering Committee updates. So this is our QAPI, which is Quality Assurance Performance Improvement, which is a federally mandated program through CMS that all nursing homes are required to have. Basically, it is our check on our quality and then how we make improvement plans if we do have any quality issues. It is a required program to have a quarterly meeting of this committee. We actually meet monthly. We have a very large campus with a lot of moving parts and a lot of different things, especially being in 3 separate facilities, lots of stuff going on. So instead of meeting quarterly, we actually meet monthly. We have 4 subcommittees of this Quality Assurance Committee that meet on a regular basis outside of this. There's many more members on that than what's on the actual QAPI committee. The subcommittees have a bunch of different members from all across campus in all different roles. And then they focus on certain things. And then instead of having everybody look at everything, those subcommittees can look at those specific things, which is just more efficient for everybody's time, as well as can hone deeper into those issues instead of a broader look that everyone might have. So then every month, one of those 4 subcommittees would give their reports from their last quarter of their subcommittee. If there was something emergent that came through any of those subcommittees, it would go on the next month. We wouldn't wait for their quarterly report. But in general, we keep to that schedule of every quarter. It's a report, so that every month it's a different subcommittee. So the 4 subcommittees are Safety Subcommittee, which is head by our maintenance team. We have Quality of Life Subcommittee that goes over the overall quality of life of our residents. So there's someone from every department on this committee, and almost every position at the campus has someone on the committee, so that we can see how every staff interaction, every department, every level of care, things like that interact to actually give the best quality of life of our residents. We sometimes go over things that we would have never thought of, but a CNA talked to a resident one time and they said, this would be really nice if this changed this way. And we had no idea about it until of this committee. So it's a really important one to just sometimes improve even just the little things in the residents' quality of life. We also have Corporate Compliance Subcommittee, which is laws, rules, ethics, all of that fun stuff. So that is headed by our Corporate Compliance Director, which would be our admissions coordinator, who is Laura Briesmeister. And we go over anything to do with billing, talk about triple check, we talk about our MDS, which is that minimum data set I mentioned earlier, go over any sort of errors that we can find, any legal issues if there are any, things like that. And then lastly, we have the clinical care subcommittee. And this subcommittee actually gives a report monthly as well as their quarterly report, because this encompasses all the clinical care that we do. So our nursing team heads this, also includes our pharmacist as well as our medical director. So it's where we go over anything clinical related. So falls, wounds, infections, any sort of illnesses, things like that, any policy changes to clinical care related things, and then as well as our pharmacy reports and our quality metrics that are provided by CMS, basically saying anything that we are above or below the average for is also through there. So this month was our pharmacy quality metrics and medical care committee quarterly report. So we had that through the committee. There was nothing alarming through that. We did review our quality metrics and nothing was out of the norm. We've actually improved in a few areas. Central is a little bit difficult right now to gauge on quality metrics because we only have 16 residents in Central with the 2 closed households. So if one resident were to have, say, a pressure injury, which is an obvious quality metric issue, it throws off our average a lot more than, say, if one resident in East or West had it, because it's 1 of 45 versus 1 of 16. So it's all based on percentages. So it's a little bit hard to gauge for our Central neighborhood right now. But besides that, we did not have any issues. We had our pharmacy reports this month as well, which looked really good. They give us reports on averages of any sort of med that is tracked. So psychotropic meds, any sort of behavioral meds, those are tracked based on averages per the state. We were doing fairly well with those, as well as they look over, did we follow the pharmacist recommendations that they gave us, and all 3 of the neighborhoods had 100% on compliance with those this quarter. So that was really good. Any questions on quality assurance? Okay. Next is the employment activity report, and I will have Chris go over that.
Okay, good morning. In your packet, and the one that was sent out, you will see the employment activity report for March. Goes through types of recruitment. I always highlight those. Those generally don't change from month to month. The next item down is the number of interviews. So in total for the month of March, we did 33 interviews. 11 of them were for direct hire, 22 were for agency. So for direct hire positions offered, it was 9, and we were able to bring 7 new people on board from those offers. So we had 7 new hires for the month of March. We had 4 resignations for the month of March. And those reasons are listed there. If we go down to the next column or row, talks about open position, numbers of open positions. That tweaks by the number of new hires and number of people that have left. For active leaves of absences, we have 22 employees with some sort of an active leave of absence, whether it be FMLA, military, educational, personal. So those people are out, not working for the most part. There are a couple intermittent leaves that are there. For the month of March, we had no lost time for work comp, which is always wonderful. And in the red italicized print on the bottom, I always give an overview of what was lost that month for staffing for COVID-related issues. So that could be somebody calling in with a sore throat that needs to be tested for COVID before they can return to work. So out of the month, there was 48 missed shifts, or roughly 370 hours. And those hours, the total hours, it's always a mix of, 3-hour shifts or 4-hour shifts, 8s, 12s, that type of thing. That's why it's kind of never matches up with 48 times 8, Does anybody have any questions on the employment report or?
Yes, Supervisor Keeter.
I was just wondering, when you hire from an agency, are those more short-term people then?
Sure, I can
Yeah.
go over that a little
Okay.
bit. So we have what's called agency staffing or pool nursing staffing. Right now, we have 4 different contracts, 3 of which are direct contracted through us. And then we also have additional contracts that are directed through the state. This is a program that the state started about 6 months ago or so to try to alleviate the staffing issues and the cost of staffing. So the state actually the state of Wisconsin contracts with these staffing agencies to send us staffing agencies, and then they pick up 60% of the bill, the state does, to try to alleviate some of the costs of staffing as all nursing homes in the country right now are struggling staffing wise. It is sometimes it feels like it's just local or just us, but it truly is everywhere. We see it at conferences, at reports, things like that. Everybody is struggling. So those agencies, the ones that come through the state, that's what those 22, most of those 22 are. We just received a new state contracted agency. So that's a lot of them come from there. So it's normally not quite that high per month, but we do have a lot of new ones that came in recently. So those would be staffing agencies that are there for short term. They're typically on about a 13 to 16 week contract, depending on the agency. So they'll be here for a decent chunk of time. There are also agencies that do what's called per diem agency. We do not do that because it doesn't typically work very well with schedules and things like that, where you would just have someone that just picked up and filled in your shifts. It's a little bit difficult because then they don't work weekends, they don't work holidays, things like that. So it doesn't help us as much. But we do the long-term contracts, which is long to us, but it is not permanent. It is shorter. It's about 13 to 16 weeks.
Thank you.
Mhm,
Did you say the state picks up 60%?
mhm.
I like that.
Yeah, it's a great program. Unfortunately, it is ending in August. So it's not a permanent fix, but they do pick up a good percentage of the bill. The one thing that we have noticed is, and it's a ongoing issue with a lot of the agency related situations of they know that we all need them. So the state is picking up 60% of the bill, but then the bill also went up for the state. So it is better than when we contract directly, but it isn't directly a 60% less cost than the ones that we contract with directly. So it's better, but unfortunately not as good as we had hoped. But and the only other staffing related thing that I was going to add is we have been talking for quite a few months about Cna Training Program. So we have worked with a company called Ready Cna, which is a Cna training program that is half virtual or done online, and then the skills and clinicals would be done at the neighbors. Currently, we do have CVTC students that do this clinical part at the neighbors, but we don't have our own Cna training program. So this would be our own program. It would be managed by us, but through this company that has online portal module kind of things that does the book learning part of Cna training virtually, so that way students wouldn't have to come into the facility at a certain time. It would be a little bit closer to what most students do now. A lot of college and high school and stuff is done online now. So it fits that model a little bit better, as well as it makes it able for them to do it on their time. So if they want to do it at 6 a.m, they can. If they want to do it at 10 p.m, they can. They wouldn't have to be at the facility for 3 hours every day to do it, or whatever the schedule would be. So we're working with them. They are a newer company to the state of Wisconsin. So they believe there's now 2, I know one for sure, but I think there's 2 facilities that have used them in Wisconsin. So it is possible to get their program certified through the state. So we are in that process right now because we do have to apply through the state to have a CNA training program. So we are using their information to do that application. So we are currently in the application process of that. Which it is a rather lengthy application, but hopefully, since they have done it before, we can get all that information and have it approved the first go around instead of having to need to do altercations to that afterwards. So hopefully soon we will have our own CNA program.
I have a question. I know that, in fact, she was contacting the state over and over with no response, and eventually you were so persistent that they did respond, but I thought we were already okayed for a CNA program.
So our facility is okayed. So part of the CNA program application is the actual physical plant. So you have to have a certain amount of space, a certain amount of tools. We have the mannequins that you use for training and things like that. So that all has to be okayed through the state, which we did years ago when we had a training program before. So all of that is still there. So that won't have to be reapproved, but the program itself has to be approved. So like our curriculum, teacher, things like that has to be approved as a new program. So that's the application part we're in now.
Okay, and do you have kind of a time frame that you're looking at?
We're hoping to have the application done shortly and get that in. I don't know the turnaround from the state. I don't know what they're currently working on. I believe they have 60 days to get it back to us, but I don't know if they use all 60 days or if it turns around faster than that. So it would just depend on how fast they are. And then once we get them in, we would be able to start. Our other situation with this is having a trainer. So we do need to have a nurse trainer for this program. So we would have to have someone who would do the skills and the clinical. So we have talked to a couple of different people and we're working on that process right now of hiring someone to be the trainer as well. And looking at how that fits into the overall system. So that would also for the payment part of this is we do not pay the company for the use of their system. Like we don't have an upfront fee, but it would be a payment fee to the company per student. So then that would be charged out to the students, which would then also include the fee for the instructor as well. So.
Thank you.
Yeah. Any other questions?
Yeah, Supervisor Breslin.
I see the homemaker and CNA were the resignations for March. Are those typically where we are losing people or having the hardest time getting people?
Yeah, CNA for sure is our biggest difficulty with getting people. It is a position that we need the most of on campus. So we have per household, if we were fully staffed with every household having full census, we would have 2 CNAs in the household on days, 2 on PMs and 1 on nights. So it's the position that we have the most of. It's also the position that everybody needs the most of and that there isn't enough of. So that is by far our greatest need. Homemakers, we do see quite a bit of turnover in homemakers, but that position is a little less difficult to fill as it doesn't need a certification. So anyone that's 18 years old and can come in and work can do that position. So that's something that doesn't need it's not as difficult to fill because it has more people that could fill it, but it is a position that we see a lot of turnover as they are part-time positions. And we do have, at least currently, we do have a lot of college age students in those positions, which they're here for a while and then they move on. So.
Have we started looking outside the box as far as retention? I know, like in my company, we've totally going outside the box as far as trying to keep people paying for the education, offering training. I'm just trying to think of how to help you here.
Yeah, so we have tried a few different things in terms of retention. We did, that was about 6 months ago or so, we did bring back our PM homemakers, which was an effort to do retention for CNAs, as we didn't have that. We had day shift homemakers instead of in both shifts to try to help CNAs out on PMs, especially when they were short-staffed. It's very difficult to do both tasks. So that wasn't something that we have done. We did a couple of wage-related changes. We did the in lieu of fringe was increased to starting right away instead of 30 days after the first of month kind of situation. That was only 2 months ago through the county board. We've done a few different things, but we're always open to any ideas or suggestions as well. So,
Thank you.
What's the time frame for CNA to get done with the program?
sure. So it's a required 70-hour class or 75-hour class that is for the state of Wisconsin. That has been changed. It used to be 120 hours. At the beginning of the pandemic, that the federal minimum is 75 hours. The state of Wisconsin had a higher minimum. They did reduce it to the federal minimum to try to make more CNAs quicker kind of thing. So it can be, so the requirement did change a little bit, but it can be spread out. It depends on the training course. So if we did 75 hours where we did full-time for 2 weeks, we'd be done. They're typically not that way. It also depends on who we're targeting for that course. So if we're trying to get high school students in, it's probably only going to be an hour or two after school timeframe. So that'll take longer time versus if we're in the summer, we could do ones that were more hours in the daytime kind of thing. So it kind of just depends, but it's 75 hours of training
Okay,
with 16 of them being clinical training. Any other questions on employment? All right. Thanks, Chris. Next, we will move on to the resident referral report, which is on the next page. So this is a report that we give every month. It looks fairly the same, except normally there is a section for the reason not admitted, which we don't have that on here right now because a lot of the reason that people aren't admitted is due to not having an open bed availability. So it's very different than what it used to look like pre-pandemic, as well as we have a lot more referrals than we did post-pandemic or pre-pandemic because we are getting referrals from all sorts of places, not just our typical referral sources. Our typical referral sources are Mayo here in Menominee, Mayo in Eau Claire, Sacred Heart in Eau Claire, and Rochester. Those are the places we typically see most of our referrals from. Now we're getting them from all over the place because there's a lot of nursing homes that aren't accepting referrals or are accepting very few for similar reasons as us. So basically hospitals are just kind of casting a wider net to see where they can find a place for someone to go. So at the beginning of the month, and these are for March, so we're about a month behind these numbers now just because of when our meetings fall. So this is from March 1st to the end of the month. So for the month we started the month at 100 residents. We had 130 referrals. That is a very large number. For reference, we used to see anywhere from 40 to 60 referrals was the average. If we had a 70 referral month, that was a big number. We now are seeing typically above 100 and this month 130. We had 16 residents admitted to the facility of that 130. We had a number of residents not admitted was 118. 2 referrals were still in the hospital at the end of the month. So sometimes the numbers don't add up perfectly just because either someone might still be in the hospital, or if we had someone that was our resident that was sent out to the hospital and they were readmitted to us, they would be in our admissions number, but not in the referral number because they weren't referred to us. So it never really adds up perfectly. So the reason for not admitting, that's primarily due to the staffing concerns. Another issue of why we may not be able to admit is if we do have any COVID situations at the neighbors, so any staff or residents who test positive, we are unable to admit to the household that that occurs in for 14 days. So we are unable to bring new people in at the risk of exposing them to someone that was in the facility that had COVID. That is a federal guidance, so that is something that we are unable to change. It is something that all nursing homes have to comply with. It is part of the general COVID policies for the federal government. So that does at times throw a wrench in things, especially if we have someone that is already planned to come to us on, say they're planning to admit to us tomorrow. They know they're coming to us and we have someone test positive in the household that had the open room today. We would have to tell the hospital, we're sorry, they can't come. So, and then the hospital is then forced to find somewhere else to have them go. So it adds a very difficult situation, but it is to help protect individuals and not expose more people. So that's kind of the rundown of that. In March, that was not a huge issue for us. We only had a couple of COVID positive staff. And luckily with our setup, we have a lot of different sections that can be easily divided. So if, say, Deerview, which is one of the households in Central, say they have a COVID outbreak at that time, and we were trying to admit someone there, we might have an open bed in a different household. So that's a benefit to our kind of crazy setup with all the different households and things, which sometimes can be difficult, but it also is a benefit at other times that we can separate households very easily and utilize admitting to a different area on campus. At the end of the month, we had 100. Oh, that is not correct. Sorry about that. That's not correct. I can get an updated number for that. So we did not have 129 residents at the end of the month, but we had 0 residents transfer to another facility. We always put that on there. Sometimes people would transfer to another nursing home. It's on there as a metric of that we didn't have anyone that was unhappy with us that wanted to move to another nursing home. It does happen though, if someone say they are from Menominee, they're admitted to the hospital here, they come and live with us, but their family lives in Marshfield and they want to be close to their family in Marshfield, we might transfer someone to another nursing home. That happens every so often. We did have 9 deaths this month. So we always put the number of deaths on here. It's somewhere normally between 5 and 10 on most months. We do have a lot of residents. We do have a lot of residents on hospice. So that's not abnormal. None of those deaths were related to COVID. We would have that specifically on here if we did have that situation, but fortunately we have not had that situation in a long time. We did have 2 residents discharge home. That number is typically higher if we have our short-term rehab households open. This month it was low. We only had 2. Next month it will be higher. We do have a higher Medicare census right now in April. So when you see this report next month, that will be higher because people were here and then discharging home, which is a good thing. It means that we did our jobs of getting them better and able to go home. I have our top referral sources. Even though we have seen additional referral sources, those 3 and then adding in Rochester as well are still our top, but we just are seeing more from kind of all over the place. We see a lot of cities referrals. We see as far as Marshfield, all over the place, just trying to find somewhere for someone to go. Any questions on referrals?
Supervisor Keeter.
Yeah, can you give preference to Dunn County residents, or would that be discrimination or something, or?
So it can be a deciding factor if we only have 1 bed open and we have, say, 2 people that the referral came in at the same time and they're going to be very similar things and situations like that. We can use that as a deciding factor of, say, we have a Dunn County resident that is going to be the same basic situation as someone from Minneapolis, we would admit the Dunn County resident. It just kind of depends on when situations happen. We never change our general acceptance policy stuff based on where someone is or who someone is. So say we have a weight limit, for example, just because some of our equipment that we use is only safe for up to a certain weight. We wouldn't say, well, this person's from Dunn County, we'll admit them even though they're over that. So we don't change those policies or trying to bring people in outside of our safety regulations, for lack of a better term. But if there are multiple people, we could say, well, this person's a Dunn County resident, we'll bring them in. And we typically do see primarily Dunn County residents. Every once in a while, we'll get some Eau Claire, things like that. But for the most part, we have Dunn County residents. Any other questions? Okay. And next, we'll go to Scott's report for the environmental and facilities report.
Good morning, everyone. I'm Scott Nobbyfeld, the Facilities and Parks Manager for Dunn County. And as Carmen kind of gave you a idea of what happens, the Facilities Department is actually separate from the neighbors of Dunn County. And we have in our Facilities Department, I have a maintenance specialist and a facility worker that are housed out of the neighbor's facility, and they do all the maintenance repairs on that facility, keep everything working properly, up and running. We recently had our maintenance specialist resign. Josh Delaney resigned the end of March. His last day was April 13th. I transitioned Brady here. This is Brady Burgraff. He is now our maintenance specialist. Prior to that, he was a facility worker for our department. He's transitioned over into neighbors. He worked with Josh for a couple of weeks to learn a lot, mainly the state regulation stuff that needs to be done for surveys. He's come on board really well with that, getting a taste of everything that needs to be done for the surveys, getting a taste of everything that needs to be maintained at the neighbors. I think his first thing he got into was heat pumps, and then after that was the dishwashers, which are typically higher maintenance. But he's doing very well on those things. So he's a great addition to the neighbors. And then the other thing I have to report is from our federal look back survey, we had an annunciator panel for the fire alarm system that needs to be added. The annunciator panel has been ordered. It is currently at the vendor. They have submitted the plan to the state, and that has to go through a plan review. So our state engineer is watching for that so that he can get that turned around. Once he's got that turned around and approved, then we can go ahead and get that annunciator panel installed, and then we'll be up to code on that. So that's coming forward. It's been a long process, but it's getting near to the end of getting that taken care of. The other things the guys are looking at is with the nicer weather, starting to get things going, cleaned up outside and looking nice. We'll get ready for the mowing season, transition from our snow to grass mowing. Other than that, doing the day-to-day operations, and things are going smooth. Any questions?
Yeah, any questions?
Scott, do you want to mention about Abrina's project with energy analysis? How that'll affect this? Because she might be in the buildings at one time.
Is she planning on doing the neighbors?
Yeah.
She is, okay.
Mhm.
So
So I
we-
don't know how that, she'll be looking at the facility basically.
So we have a UW Stout student that presented a proposal at the facilities committee meeting last night. We decided to go ahead with that. It'll be happening this summer. I'll be mainly working with her on gathering information for energy consumption and data on each of our buildings, so that she can put together a report and recommendations of going forward, how the county can save money, which direction we can go as far as our process of getting to be carbon free by 2050. So we'll be working with her. I'll be having her come through the buildings and give her a tour and and get her any information she needs to put together her project.
Yeah, and thank you, Don. That's an example of people being on different committees, sharing information. And that's something that we were fortunate with Dave Bartlett, because he was always here sharing what the other committees did. So as I don't know if you're in other committees or not, I can't, but not yet, but that's one thing to look for. And I would encourage you guys, two newer people, especially because you can get some per diem for it if you want to attend every committee that you can have a chance to look at, because it gives you an idea of the staff. Like seeing Scott, you're going to see Scott at a lot of different places and so forth. But hey, yeah, thank you, Scott and Brady. Welcome. Thanks for sitting through and listening to this.
All right, thanks, Scott. The next update is fundraiser update. So this is a recent addition to our agenda for the NDC meeting. We are currently in the process of fundraising for a new bus. So our bus is 22 years old, which is very old for a bus that gets a lot of usage. So this bus is used to take residents to and from activities and outings in the community, which is very important and something that most of our residents look forward to greatly. It's been difficult, especially over the last couple of years, just with safety concerns and going to public places and things like that. And for a while, it just wasn't possible. Now we are able to do that again, especially in the summertime. It's used seemingly daily to go do something. So it's a very useful and important thing to have. Ours is at its 22 years is struggling with a lot of different issues. The maintenance team puts a lot of time and work into keeping it functional and safe. But at this point, we are trying to fundraise for a new bus, as it is a very expensive item. It is something that we have attempted to budget for in the past, but it just hasn't made the cut with the budget constraints that we already have as the neighbors and then as the county as a whole. So this year we have, this year and last year have put a lot of effort primarily by our activities department. Alyssa Dowdy is our life enhancement mentor, and she's done a lot of work as well as our fundraising committee to do a lot of fundraisers to make money to buy a new bus. So we have done quite a few fundraisers. Some are really big fundraisers. Some are fairly small fundraisers. Yesterday we had one that was a soup and sandwich sale. We used to have a bistro at the neighbors that was closed at the beginning of the pandemic, just to not have a bunch of people in and out uncontrolled. So we have not reopened that as of yet. It is something that we are looking at doing. But as of now, we've been doing monthly lunches that people can pre-order. So we know the amount of people coming in. We can have a staff member there to kind of check people in and make sure that they don't go anywhere, but just to the bistro front area and back, and don't actually sit and eat at the facility. But those have been fundraisers for the bus at this point. They're very good fundraisers, and everyone seems to like them, as many of the county staff here at the government center, as well as the staff at the local businesses, really miss the bistro as a lunch option. So we've seen a really good turnout for those. Other things we've done is we did a 5K in October this past year. It ended up having to be a virtual 5K, but we did have some participants in that, as well as we did an auction or not an auction, a basket raffle. We did go through the process of getting a license to do raffles. So that has been another good fundraiser for us. Looking forward, we are doing a golf tournament this summer, which is typically, we've never done one, but that's typically a fairly good fundraiser, as well as more meals and working on being able to be fundraising people at different events, at local events. So we've looked at Country Jam in Eau Claire, I believe the Blue Ox Music Festival in Eau Claire, and doing a couple of different fundraising things like that. We'll also be doing the pies at the band concert one one Wednesday this summer too, which is a fairly coveted thing, especially since it's the first time they're coming back. So we were really excited to be contacted to be able to be the pie people for a Wednesday. And it's very fitting because that is one of our residents' favorite outings that we do take the bus to. So the bus will be there with our residents while we are serving pie. So it's a big target. A bus with all of the fixings and things we need is we're estimating at about $90,000. It's a very expensive item. It has to be wheelchair accessible for multiple wheelchairs. They are not cheap. Right now, we're at roughly $20,000 that we fundraised, and we've not been doing it yet a year. So we're getting there. We've also applied for some grants. So that's actually later on the agenda. During the action items, we received a grant so that from the Community Foundation, which will actually be physically receiving today. But then that has to go through the budget adjustment process as well. And we have applied for some other grants to be considered for too. So we're working on it. Any questions on fundraising?
Scott, would that be a candidate for a lease? A bus like that, or is that pretty big or something?
I could check into it to see what it would be. I know when we leased our one van that has the wheelchair lift on it, you end up having to pay money up front for getting the installation or the wheelchair lift and the installation there.
Yeah.
But I can look into it and see what they have to say. I have an upcoming meeting with Enterprise for leasing, and it never hurts to ask.
We've also tried to work through the transit, Dunn County Transit, as well as through the DOT's transit program. And that's one of the grants that we're working on. We do know that that's kind of a long shot since we roughly qualify for it. So we're hopeful for that. But that's another idea that we have had as well as looking at the retired transit buses too. So some of them would work very well for us, but some of them don't have the wheelchair capacity that we would need because they have more seats than they do open space.
And I think at a meeting, our last meeting, Supervisor McCullough asked you about electric buses and the possibility of going through the highway department or something like that, or grants, state grants.
So that's part of that DOT grant that we are looking at. I know Alyssa has done the initial submission for it, to kind of like put our name in the hat. The actual grant application that goes through the DOT that includes the electric buses, the grant cycle starts in June. So that's something we'll be looking at then.
Thank you.
Yeah, that'd be a really good candidate for an electric bus
Mhm.
because it's just short trips all the time.
Mhm.
isn't it? Yeah.
Any other questions on fundraising? All right, the next update is COVID-19 update. So this is something that we go over every month and kind of talk about any changes that have occurred. As we have a lot of new members, if you have any questions about it, once I'm finished, we can talk about them because there's obviously a lot of things that have happened prior to this meeting, but I'm not real sure what everyone would like to know. But I can give the updates of what's occurred in the last month. And this one I typically do real time. A lot of this is the past actual month. If it's numbers and things, I try to do this one real time since it changes so frequently. Over the past month or so, we still have seen some COVID cases. We did have a very brief kind of relief from COVID where we've had less staff cases. We had a very long time without any resident cases. Unfortunately, just yesterday, we had a significant outbreak in our West building. We had 7 residents test positive in one day. It is fortunately, all of these residents are doing well. Only one had a symptom. That is how we discovered the outbreak. A resident had a cough, and anytime we have a resident that has a symptom, we test them immediately and have them on isolation until we figure out what's going on. This resident tested positive, And then anytime that we have a resident or staff member test positive, any resident that lives in that area or would have had contact with the positive person, we're required to test them immediately. So then basically that whole household was tested yesterday after the first person was, and through that process, 6 more residents were identified. That household is a very lively household that all of the residents enjoy each other's company a lot. So it's not surprising that when we had one resident, we would have a lot. It's a great thing. They all eat every meal together. They play every game together. They do spend a lot of time together, which is a very, very good thing for residents' well-being. But unfortunately for situations like this, it does cause some risks. So fortunately, all 7 residents are doing okay. Only that first resident has any symptoms and they're very mild. So we're very fortunate for that. This is one of our bigger outbreaks over the course of the pandemic. We've only had a few COVID outbreaks when it comes to residents. In November of 2020 was our biggest outbreak. We had 12 residents in the East Building test positive, and 4 of those residents passed away of COVID that was pre-vaccinations and when we still did not allow out visitors. So that was a very difficult time since then. COVID has adapted. We have had multiple policy changes. We've had multiple procedure changes, vaccination, all sorts of different things. And now we're very fortunate that situations like that are less likely to occur. Now with our 7-person outbreak, hopefully all of our residents may remain asymptomatic or have very mild symptoms, and we don't have a situation like our first outbreak. But it is something that we are monitoring at this time. And then going forward through this outbreak, anytime any residents test positive or a staff member test positive, the outbreak lasts for 14 days after the last known positive. So with all of these residents testing positive on the same day, it all counts as one day. So then today would be day 1 of the 14 days. And then after that would be when that outbreak is considered complete. If we have additional residents test positive or staff, then that 14 days starts over. So say we do, and we have to test every 3 to 7 days, all of the residents in that household. So say the next time we test, another resident tests positive, then those 14 days start over again. So it can lead to lengthy outbreaks. It does happen, but hopefully we can clear this up quickly and go from there. And currently during outbreaks, visitation is not stopped. We are able to have visitors. Just all visitors when entering the facility must wear a mask. That hasn't changed since the beginning of the pandemic. And then they're screened at the door. So our doors are currently locked just because we have 12 entrances on campus versus a typical nursing home might just have one main entrance at the front. Due to our setup, all of those households have a separate entrance, and then we have a front door, as well as there's other entrances on campus. So we can't have someone staffed at every single door to have the doors open. So all the doors have doorbells on them. So if a family or friend comes to the door, they ring a doorbell, and then a staff member comes and lets them in and screens them. It is a requirement through the federal guidance that we screen visitors before they enter the facility. So that is a requirement. We have to tempt them and then ask them screening questions regarding symptoms, exposures, and COVID positivity or their COVID status. We don't ask about vaccination. Visitors do not have to be vaccinated, but all staff and anyone providing a service at the Neighbors is required to be vaccinated or have an approved exemption at this time. And that is also per federal mandate.
I'm curious, do the residents have to stay in the room then if they've had the COVID?
So the residents that are currently COVID positive, yes, they are in their room on what's called COVID precautions or isolation. And then any staff member or anyone entering the room, staff member, anyone providing a service from our facility entering the room must wear an N95 mask, which are masks that you have to be fit tested for that don't allow particles in. It's the ones that you see that cover your full face that are very tight. Those, they have to wear an N95 mask, eye protection. So we have goggles or face shields, and then a disposable gown when entering the room. And then that's all taken off, and the mask is reused for that room only. So they have a separate N95 mask for every resident's room that has COVID. And then those residents are in their rooms. The other residents that would have been affected by this in that household, we try to keep them in their rooms as much as possible, just as that's the safest, but we don't fully isolate them to their rooms. We do require them to stay 6 feet away from other residents, because say resident A, which was the first resident, had seen resident B, but they haven't tested positive yet. They still could be infectious before their actual test, and we wouldn't want them to give it to someone that wasn't exposed to the initial person. So we keep them separate out. We ask residents to wear masks if they can when they're out of their rooms. Doesn't happen very often. If they don't want to, we don't make them, but we ask them to if they can. We do have some residents that just simply can't either, just due to conditions, or say they have oxygen on at all times, things like that. Or they just can't keep it on. So we try to keep everybody separated out and stuff during that time. We don't do communal dining during an outbreak, and we don't do communal activities. So we can do activities where we do kind of what we did at the beginning of the pandemic, where we keep people 6 feet apart. Doorway bingo is something that was a big thing. We were very, very fortunate to have in-room TVs that have streaming from our chapels, which was designed that way when the building was designed due to our spread out campus and having kind of smaller community or general areas. All of our TVs have a TV channel on them that you can view each of our chapels. So if we have a situation where residents can't gather together, we can still have, say, live music or a program that an activities individual or religious person, if we have church, whatever it might be, will be in the chapel giving this program, and it is both audio and videoed to each resident room. So that way, if anyone is required to be in their room, or if that is just the best option at the time due to the risk, they still can have some life enhancement programs that are offered to them as well. We also will do like in-room things, like room to room, the activities staff will go and do one-on-one sessions with people and things like that as well.
Thank you.
Any other questions about COVID or the current COVID situation at the neighbors? All right. So that ends my general community mentor administrator report. Is there any other questions for me specifically before we move on to financials and other action items? All right, that concludes my report.
Thank you. And Jane is up then?
Hello, board. My name is Jane Hanson. I'm the accounting manager. I work with NDC, Public Health, and some other general department-wide projects that we have. I've been with Dunn County 2 years. I spent 20 years with St. Croix County in various departments, but mostly doing skilled nursing and DHS finances. And currently I'm with, I do the public health and NDC here. I have 3 staff members. I have 2 billers and 1 senior billing specialist, and the success of our collections depends on keeping those staff trained and employed, keeping our staff, and then getting them trained and moving on from there. So that's who I am. First, the vouchers. If you're going to turn to your vouchers page, I can explain how those are run. The dates are at the top, showing when we ran those reports, and the sorting kind of tells you how the accounting system works. When it says NDCE, that would be East, and then administration would be those items that post to Carmen's administration account. And then it goes from there. We've got the nursing department, the dietary department. And so things are sorted in that manner. So you'll see the whole page of, you'll get to NDC Central Administration in the middle of the packet. The vendor name is on the right-hand side, and of course the amounts. Some of our invoices are split 3 ways evenly when it's applicable, and many of our invoices are specific to a certain building. So that's the overall how we get to this report. Are there any questions on the entries in the vouchers report? No?
I guess not.
Okay. If you ever have any questions, ask Carmen or myself, and we can certainly explain whatever needs explaining. Then within the packet, I'll go in the order that it came out of my printer, and I think it's the same as yours. The amount paid for pool staff. It's a landscape document. We have done this in every month, and it adds up what's been posted to our general ledger. So in March, that's the cutoff date from March, may not include all the items in March because the bills come in April as well, and then they get posted to April. So we might be a month behind or half a month behind in posting some of these. What happens is in December, it gets caught up, and then December always looks like a heavy month, but it's actually clearing up that delay in invoicing. So East, West, and Central all use pool staff. And the amounts in the totals are there. East has used 362,000, Central not so much, and then West about the same as East for that year-to-date number. The prices have gone up for staffing during COVID, and for whatever other reason, the supply and demand. So we are at almost 50% of what we spent in 2021. And it's only been 1 quarter in 2022. So I do expect those costs to go above what we did in 2021 as far as the cost for pool staff. Any questions on that? No?
No, I guess not.
Very good. Moving on to the aging report. And I think it's important that we go over, at least the number for the aging so that we have some transparency as to what's going on in billing and what we're collecting. So there's no surprises at the end of the year. What we have here on this aging report for March is 3 boxes. So we've got January, February, and March. So you can see a trend. What I look at, and maybe what you might find most valuable, would be the AR aging summary total. So on that last line of each box, the second box in, where it says outstanding balance for each of those 3 months. So it's got $1,000,001 in January. In February, if we bounce down to that outstanding balance in the AR aging summary total, got 1.166 for the outstanding balance. And then in March, we've got 1.103. So it's pretty stable. And that's maybe as a board what you want to see. And if it's not stable, ask questions, what's happening. If we open up the other 2 units in Central, we would expect the aging to increase because we're billing more revenue as well. So we have more outstanding. So you want it to be reasonable. And also the very end number on each box, the AR aging summary total, is the really old stuff that we have a difficult time collecting on. And right now, total campus-wide, we've got the, in January, we had 179,000 outstanding. In February, we have $176,000 outstanding. And in March, $167,000 outstanding. So that shows that we are collecting on some payment plans, some older claims that are getting settled that we still think we can collect, or we've written off something. So that's, we don't want that to get any higher, but sometimes it does if we have difficulty. As far as what we're billing, if you're interested, at some point we can show, well, in the other next report, it'll show the Medicare, Medicaid, that breakout of what our revenues are. We can also split that out by aging. And a lot of times the VA, we get stuck on the VA claims payment. We had a claim pay this month that was over 2 years old. It finally got paid. It went through, it just got stuck in their payment system, but we do get paid for VA. So we never will write off that kind of revenue.
If I can add one thing in there, Jane, with the VA payments, they typically are one of our better payments terms of like for the actual day of payment, like the cost per day. But they do take quite a while to have payment come through, as well as they've gone through a lot of changes with their systems and who does what. So hopefully that's something that'll be improving, because they did just change over a lot of things. So VA has always been one of the ones in that bucket that is a little bit longer outstanding.
Yeah. And we've worked to
And-
improve. Oh, go ahead.
Just to confirm, it confused me, but aging, we mean money that's owed to us. And
Yes.
since Jane has started, she's done a really good job of explaining it. And it's nice to see. And she has been collecting, albeit slowly sometimes by necessity, but she's done a really good job with this. Thank you, Jane. I mean,
You're
continue, but thanks for doing that.
Thank you. And critical to having a good aging percentage and numbers coming for the dollars coming in, having the right billing staff is critical. Otherwise, we end up with write-offs if we can't collect, because there's timely filing, timely appeals filing. If something pays incorrectly, we only have so many days to appeal that, or else it's lost revenue. So right now we are fully staffed. I've got Ashley Faulkner, Elizabeth Olson as our main billers. Ashley's been with us 1 year, Elizabeth just since January. So we have some new staff there, and I work directly with them, and we train and we improve our systems. Carol Hafferman is my senior billing specialist, and she works on training the billing staff as well, and she does some payables, kind of a jack of all trades. So right now, I think we're sitting pretty good with our staffing. And that is directly involved in our good results. Any questions on the aging report and how to look at that, or what you want to look at? Not yet.
No, I guess we can move on.
Okay. The next item is a campus census, and that speaks to what we budgeted. The lines going horizontally, mine is not in color, so it's harder to look at, but like up at the top, you've got the Medicaid census, that line that none of the bars are touching. That's probably not the best thing, because we do have those 2 units closed, but our census is lower than what we budgeted for. And on the next pages, you'll see that our expenses are lower than we budgeted as well. So Carmen is really good at making sure if the revenue is lower, the expenses are lower, and we're still in a good financial situation. But this one is by the payers. So VA doesn't have a lot of payers, or it doesn't have a lot of residents, but it's still pretty stable. So Medicare is the one that we keep an eye on. And right now we have, I think, 22 people on Medicare campus-wide. It's the most since I've been here in the last 2 years. So it's a good thing that the lines are going to change a little bit for next month. Any question on the census?
Oh, looks good.
Okay.
If I'll just add one thing, Jane, so just for reference for our new members, we did budget this year, our census as if COVID didn't exist. So that was the guidance for the last 2 years, was because it is a lot harder to add in more if we did better than to just adjust. Because then we got into this a couple of years ago where we had to do budget adjustments every month because we were above what our targeted census was, and then to accept the money as well as to then spend more money on, say, food or medications, things like that. We were doing budget adjustments every single month on things. So this was basically we budgeted higher in case our situation with COVID and changed, and we were able to have more, as this has continued for 2 years now, and the staffing situation doesn't appear to be getting better. This will probably not be the case next year. So that was just the idea, was in case it improved, it was a lot harder to go the opposite way, just for reference of why those are so off.
And also the budgeted amount plays into some of the calculations for those provider relief funds. Dunn County has been very fortunate to get a lot of provider relief funds through the pandemic monies that's specific for nursing homes. And some are more targeted and some are more general as far as usage, but the calculations to get to some of those sub-grants use budgeted amounts versus actual amounts. And so it was important to budget, I think, as if we didn't have COVID. And then we know where we're standing as far as what normal, how far off of normal we are. Yep. Thank you, Carmen. Okay, moving on to the income statement. I'll review the campus sheet, and if you want to look at those other ones, those are just backup. But the campus income statement is through March 31st. The top line is the budgeted occupancy rate. So that's a rate as far as numbers go. 87 was what we based our budgeting off of, and that's where we base everything else off. How we do that is we want the rate and then we split by payers and get the numbers. The average daily census, that's the actual number of people, not the percentage. We budgeted for 119. Our average daily census is 96. So that shows you the reduced population there. The actual monthly occupancy just for March was 71%. And the actual year to date for all 3 months is 70%. So we're moving up a little bit there. Then when we look at the income statement, the revenues are on top. We've got the actual month to date, the MTD, and then the actual year to date in the fourth numerical column, and then the expenses down below. What I like to look at is the actual year to date, and then the actual year to date expenses. So it will tell you the story of the revenues that Medicaid is below where we budgeted, and private pay is below by a higher not by a higher percent. But the year to date is 3,080,000, and the budgeted was 3,600,000. So we are below where we budgeted. Go down to the total expenses. We budgeted, the actual year to date is 3,151,000, and the budgeted year to date was 3,690,000. So we're not off a whole lot. We're off by that 538,807 as far as the expenses go. Going back up into the expenses a little in more detail, the property ownership line looks to be off because we don't post depreciation every month because of other things within our computer system. We want to make sure certain things are set first and depreciation is run last. So we've also put that in at the bottom. It will be an expense. It's not a cash expense, but it is something that comes on our books on paper, and you'll see it in the annual report as an expense. So if we add the totals of the actual year-to-date revenue and subtract the expenses, add back in that depreciation of $170,000, we come up with a net campus loss of $242,000 year-to-date. So East and West have been pretty positive as far as their cash flow, and Central still has overhead costs, and that's what this pretty much reflects, is that we have overhead costs that we still have, but only 1/3 full of the building. Any questions on the financial reports?
Yeah, you did a nice job of an overview, and that's good as we go through it each time. I think we'll get a better feel for it.
Yeah, if you have any questions, please feel free to give me a call or Carmen.
I could add a couple of things on this. The only couple of things I'd like to point out that are different than what are the regular things that you would just see as operations is the bistro is still on there. That is, I talked a little bit about that during the fundraising. We did budget for it as we were hoping that it might open, kind of as if COVID wasn't there. As you can see, it looks like we're losing $5,000 in the revenues, but there's also no expenses. So those just cancel each other out. The other one is senior meals. So we are the senior meals contract for Dunn County. So we make the meals that go out for the Dunn County Senior Meals Program. So that is also on there as both a revenue and an expense. So we do make a small margin on the senior meals program, but then it is also we're the supplier for the food. So that's another thing on there that is different than nursing home operations. Just thought I'd point that out as they're a little bit, different.
And also within the senior meals, you won't see any revenue. It wasn't posted when I ran the report, but it does come in every month and is pretty much on target for the amount that's posted. And donations in that miscellaneous revenue line. The donations year to date for the bus are about $7,000 now, just for the year to date, plus what we carried over. We also get land rent, and that was over $9,000, and that posted in the first quarter. So that's part of that miscellaneous revenue, is the land rental for the farmland behind the neighbors. There are a few expenses that weren't posted as well because they're coming in later. So in the end, it kind of balances. So I think you're getting a true picture of the status of the financials for the first quarter.
Thank you, Jane. Now, Carmen, do we need to approve or accept the vouchers and financial reports now?
Yes, so we need a motion to approve in a second.
I would ask to accept rather than approve, accept the vouchers and financial reports.
I'll second.
Supervisor Breslin,
I'll second.
you should second. Okay.
Oh.
Oh,
Okay.
well, Supervisor
I'll
Breslin
I'll move to approve.
and okay. And Supervisor Keeter was the first. You tricked me there. Any other discussion on that? Then all in favor, aye.
Aye.
I heard everybody say aye, and there are no opposed and no abstentions.
Okay. The next item would be our budget adjustment that Carmen mentioned earlier. What we have this time is a budget adjustment that will go to executive committee and then to the full county board. Our computer system is set up so that we don't put money into the computer system unless it's been approved by the board. We certainly can't expend the funds without permission. We can always, deposit it somewhere, but we want to put it in the bus account. So this grant that we are accepting from the Community Foundation will be put into a local grant account within our computer system and be saved for the bus expense. And that needs approval by the board.
Okay, and this is the meeting that you have to go to in just a few minutes to
Mhm.
accept this grant? Okay. So it's described in here and you mentioned it a little bit earlier. Any questions about this first? Then I'll accept the motion to approve the budget adjustment for the Community Foundation grant.
I believe it has to be to send to executive. I think
Okay,
because this has to go to executive, so.
so we would approve the budget adjustment for the Community Foundation grant and move it to the executive committee. So I would take a motion to that effect. Don, Supervisor Keeter,
Second.
thank you very much, Carly. Supervisor Witzel, second it. Any other discussion? Then all in favor? Aye.
Aye.
Again, it was unanimous. Thank you very much. And this goes on to the executive committee.
We will just make one adjustment to it, as this was originally created when Chairman Bartlett was the chair. So we will adjust that to be Chairman McCullough.
Oh, are we at 7 then? Okay, number 7, I'd like to be able to set a time where we can all come. As I understand it, Supervisor Bjork won't be working for a while, so he has some flexibility. The past meetings have always been at 10:30 on the third Thursday, 10:30 a.m. on the third Thursday. And Carmen, I remember we wanted to set it at 9 and it got changed to 10:30. Were rounds going on, or was there a reason that?
So I believe, so this was before my time of when the meeting was set. I believe that was Dr. Brown wanted to come to the meetings, who was our previous medical director. And he rounded on this day at the Neighbors as the rounding physician. And it wasn't feasible to get here by 9 when he was rounding. Dr. Brown is no longer our medical director. Our new medical director actually will be attempting to come to one of these meetings. He's still, when Dr. Brown was our medical director, he was only the medical director at the Neighbors. He didn't work at the clinic or the hospital anymore. So he had more flexibility. Once we have a meeting set, Dr. Phillips, who is our current medical director, said he would try to arrange his schedule so that he can make it, but he is booked out for a couple of months with regular physician appointments at the hospital. So, but I don't think that that would be an issue, as he would not be rounding every day like Dr. Brown did.
Okay, thank you. Then how does 9 a.m. the third Thursday of the month sound to?
Works for me.
Works for me.
What's for you?
I just have to get up a little earlier.
Well, yeah, it's early for me too, but yeah, then we can get the day, and your employer has graciously given you some time off?
Yep.
That's wonderful. Huh?
They've given me as much time as I need during the day. That's why I was open to whenever, but early mornings work better for.
Then you can go back,
Yeah, I
it's
can
not in the
go
middle of
back
the
to
day.
Hammond. Yep.
Okay, to Hammond.
Yes.
Yeah, okay. So then I guess it's Carmen, it'll be 9 9
9 o'clock
a.m.
on the third Thursday.
Thursday, and this meeting was to kind of get us going. It was an unusual one, but it's probably a little longer, and that's my fault because I asked everybody to kind of give a little bit more background. And as we go along, I hope maybe we'll dive into some of these things a little deeper. And there is one thing I would ask you to do, is I'd like you to take a tour of the facility and people. And the facility is more than facility. It's just a cool place. And if you could, would you take a time within the next month or two and email Carmen and set up a time for a tour? And I prefer that you do it individually, and I want to come along
Okay.
because I'd like to get to know you better,
Okay.
and I could use a tour too. I'll get maybe 3 tours, but that's okay. I'm a slow learner. But so if you could do that, and I'll work with her, and I look forward to that.
Try to get a tour when it first was opened, and I didn't make it because I really wanted to go through the facility. Being that I've been a CNA myself, I kind of understand what she's been what she's talking about. So I get the drift of things pretty well that
Right.
way.
Yeah, you don't want to go back to work, do you?
No, no.
Is there a better time or a worse time or?
No, I guess for seeing, if you want to meet staff and people and see, I would say avoid meal times would probably be the best because it's the busiest for everybody. That would probably be, I mean, most likely wouldn't be there breakfast or dinner, but avoiding lunchtime would probably be the best. But besides that,
So you're talking 11 to 1, kind of?
yeah, I would
Okay.
avoid that
11 to
time.
1?
11 to 1 would probably
Okay.
not be best, just staff are really busy at that time with prepping meals and then after meals.
Mhm.
Most residents either need to use the restroom or a lot go to bed for a little bit if they want a nap. So that's always a hectic time.
Yeah.
So
Yeah, I
Okay.
understand that one.
Now, Carmen, just to make sure I don't go afoul of open meeting laws, I was going to suggest that I just be included when you deal with each person and set up a meeting time, but I'm not sure if that's a good idea.
I can check with Nick to make sure, but I believe you have to have 3 to have a quorum. So I think it would be fine.
Two is okay.
Two would be
I'm
all
pretty
right.
sure,
Mhm.
yeah.
Okay. Okay.
So yeah, I can double check with Nick just to make sure we're doing everything right, but I believe it would be okay.
Well, right now, 2 wouldn't be okay because Larry Bjork isn't here. And 2 people could block
Ah.
something. So right now it's not okay. But anyway, so just keep that in mind. And I look forward to getting a tour myself. And I look forward to getting to know you a little bit better. And I've known Don for a while, but I could get to know you better too. He knows my wife much better than me. So,
Yes, thank you, Carmen, for the whole review about the neighbors. It was very interesting.
Yeah.
course.
Very
Yes,
good.
thank you very
well
much.
done.
That's
Thank
great.
you.
Yeah, learned a lot.
Anybody else have anything? Then we are adjourned.
The next meeting will be May 19th.
Yep.
Just so date
That's
wise.
quick. Good.
Or
So
is
we
it?
come the day after the meeting then,
Mhm.
right?
Yes.
The 18th is our meeting.